Good afternoon, everyone. First of all, I would like to thank organizer for the invitation to participate in this congress. I'm going to talk about sentinel lymph node biopsy in papillary thyroid carcinoma. Papillary thyroid cancer accounts for 90% of all tumors affecting the thyroid gland. The incidence is increasing by around 4% per year, and it's the eighth type of cancer that affects women. Papillary thyroid cancer has a good prognosis with a low long-term mortality of around 2-4% and recurrence are around 10-30%. The treatment of PTC has changed over time. In fact, many years ago, tumor resection was considered the appropriate treatment, and then Mowat in 1953 postulated that hemithyroidectomy was a better treatment. But it's in 1981 when Mathaferri published an article that changed the vision of treatment. In his article, he talked about tumor size, nodes, metastasis, recurrence, and mortality. He concluded that there were more aggressive tumors in which a total thyroidectomy would have to be performed. This idea is now accepted and even reflected by the American Thyroid Association in its publications. Currently, thyroidectomy or hemithyroidectomy based on tumor size and lymphadenectomies of cervical compartment affected by lymph node metastasis are accepted. But there is still no consensus on prophylactic lymphadenectomy of the central compartment, and it's in this matter where sentinel node biopsy can help. Risk stratification system proposed by American Thyroid Association said that the presence of metastatic lymph nodes will increase the risk of recurrence. So the diagnosis is very important because it will define the type of surgery we should perform. And which is the best diagnostic test for thyroid cancer? Of course, ultrasound. Ultrasound is the gold standard diagnostic test, but it has limitations, especially for the study of lymph nodes of the cervical central compartment, where sensitivity and specificity are 30% and 86% respectively. The presence of these lymph nodes metastases range from 25 to 90%, and it's associated with increased tumor recurrence. Some items are accepted that all surgeons should not forget. Surgical resection of the tumor should be as complete as possible. We have to reduce the morbidity associated with the treatment, to perform a correct staging of the disease, and to allow an accurate long-term control. The first article published about sentinel node biopsy in papillary thyroid cancer was made by Kellerman in 1998. Since then, many authors have published on this subject. Here in Spain, Álvaro Larraz was the first who published an article about this, and all of them have similar results and conclude that sentinel node biopsy can be used in papillary thyroid cancer. In the same sense, Balasubramanian in 2014 publishes a meta-analysis concluding very similar results. And what's sentinel lymph node? The sentinel node is defined as the first to receive lymph from a tumor site. Its value lies in the fact that its histological status predicts the status of the other nodes. So, if sentinel node is affected by metastasis, the rest of the nodes in the cervical compartment may also be affected. The decision to perform the sentinel node technique must always be supervised by a multidisciplinary committee. We can't forget that to perform this technique, we must have the help of radiologists and nuclear medicine. And how is made? 24 hours before surgery, we perform the ultrasound guide intratumoral injection of technetium-99 with nanocolloid. Then, with the planar lymphoscintigraphy, we locate the position of the sentinel nodes and mark the location on the skin. During surgery, we perform total thyroidectomy. Then, with the portable gamma camera proof, locate the sentinel nodes, remove them, and send them for intraoperative study. If sentinel nodes are positive for metastasis, we perform the nodal dissection of the compartment affected. And these are our results. With 53 patients, sensitivity was 86%, specificity 100%, detectability 96%, and false negative 7.5%. The accuracy of the technique was 92%. Increasing the number of our patients, 100. Sensitivity was 89%, specificity 100%, detectability 93%, and false negative lower, 5%. The accuracy of the technique, 95%. And what does these results mean? All our patients had a preoperative ultrasound without metastasis. In the study of the first 53 patients, excluding false negative, the sentinel node biopsy told us that 49% of patients had no affected nodes. So in these patients, we shouldn't have done the nodal dissection. But in 51% of patients had affected nodes. And of those, 28 should have done the central neck compartment dissection, and 22% the central and lateral neck compartment dissection. Of course, false negative, 7.5%. And by increasing the number of patients in our study, 100, here again without excluding false negative, the sentinel lymph node biopsy told us that in 51% of patients, we shouldn't have done lymph node dissection because the nodes were negative. In 27% of patients, we should have done the central compartment dissection, and 21% of patients, we should have done central and lateral compartment dissection with 5% of false negative. So the data are corroborated. To conclude, the selective sentinel node biopsy tell us correctly whether or not we should perform lymph node dissection and which cervical compartment should be removed. Thank you for your attention. Thank you so much.